Dr. Aditya Pradhan. He will be talking on ocular burn classification and overview. Over to you, Dr. Aditya.
Yeah. Very good morning to all of you. So I'll just start with the presentation. We'll take a quick overview at the classification of ocular burns. I have no financial interest to disclose. So basically anything which is caused by a chemical or a radiant energy injury is called as an ocular burn. So as we all know, it's a true ocular emergency and extensive damage, and it causes significant morbidity as well. Sometimes it can lead to blindness if not properly treated on time. In developed countries, the incidence ranges from 1.25 to 4.4%, and here in countries like India, it is much more, and more commonly seen in men because of either workplace-associated injury or at home or in assault as well. So if you see the data from the Western countries, the household cleaning agents, personal care products, automotive chemicals, glues and adhesives, they form the bulk of the causative agents in ocular burns. And in the household group, we have bleach and disinfectant hair products, which also cause significant amounts of chemical injury. And in the United States, if you see, there is a bimodal distribution peak. So one peak is in between 0 to 5 years of age in the pediatric age group. And then again, as the person starts going and working outdoors, so maybe from the age of 15 till the age of around 45, we have a second peak in which there is a lot of morbidity to the surface. And with time, as the age increases, the incidence of injury goes down. So in India, we have very few data. This is an old article from 93 in which again alkalis were around 36% of the cases, acids were 48%, and then some miscellaneous agents. But as you can see, the factory workers, those and working in the laboratory as well, so they were significantly affected by this. And this is the article from RP Center. So we have data for the pediatric age group as well. So patients aged less than 16 years were included in this. So in the preschool group, the injuries were more severe and were associated with severe visual loss. Alkali injury from the bursting of tuna packets was the most common cause of injury in the pediatric age group in North India. So if we go to the classification, we have a timeline which started with the article in 1964 by Ballen. This was modified by Roper Hall, which is called as the modified Roper Hall classification. And briefly, one article came out in by Pfister in ophthalmology, which showed you have to match the presentation of the eye with the pre-printed photographs. And now currently, which we are all using is the classification by Dua, which came out in 2001. So if we have the Roper Hall classification, we have only 4 grades in which we look at the corneal epithelium, we look at the conjunctiva and the limbus, and then the prognosis ranges from good to poor in grade 4. And this is the Pfister classification which we don't use, but we have to just match the appearance of the eye with these photographs. So it's not very accurate, but maybe just to get a rough idea at maybe a primary care center, you can use this classification. And then Dua modified this, and we have 6 grades now. So the prognosis ranges from very good to very poor. And number of clock hours of the limbus involved is what we see in the clinical findings. We also look at how much percentage of the conjunctiva is involved. So, but we all know this classification is somewhat incomplete. But the prognostic value of Roper Hall and Dua classification is, Dua is better because it subclassifies into the grade 4 into 2 more, grade 5 and 6, so it is more comprehensive. So what is new in the classification system is the calculator which was introduced by Dr. Geeta Iyer and group from Shankar Netralaya. So this is based on the I&E system of management of ocular injuries, in which this part is the conventional which we all know by Dua, L1, 2, 3, 4, 5, 6. This is the EPICS. EPICS is E stands for epithelium. We have 3 types of epithelium which are damaged by chemical injuries, that is conjunctival, corneal and tarsal epithelium. Then P stands for pressure, I stands for ischemia, and X is the amount of exposure especially if the lids are involved. And based on that, there is an online calculator which I'll just show a screenshot. So this is the freely available calculator on the website, in which you have to just enter these few demographic details. Is it a unilateral or a bilateral involvement? And then you have these drop-down menus in which you have to select the amount of injury as per what you see on the slit lamp. And then it gives you the grading and the prognosis. So as we all know that since the time of Dua's classification, that limbal ischemia is the most important factor, prognosticating factor in the final outcome of chemical injury. But we still don't have a reliable assessment that somebody may call it ischemia, somebody may call it blanching. So we still don't have a reliable system. So as you can see in the top photo, that is P1 on the top left, it is definitely there is a lot of corneal involvement, but the conjunctiva is sort of blanched. But if you look at the bottom left and bottom right photographs, this whitening is definitely ischemia. So there is sometimes a confusion in the very early phase of injury that what is blanching and what is frank ischemia. So there are being certain modifications which are being proposed. One is which is using the fluorescein angiography for the anterior segment, in which you can just push the dial like our retina colleagues do and then take photographs of the anterior segment, see where the ischemia is, and then perform tinonplasty more selectively rather than performing a near total procedure or a more severe procedure. And the next modality on the block, again inspired by our retina colleagues, is the OCTA, that is the anterior segment optical coherence angiography, in which no dye is needed, but that is definitely more reliable than just clinical examination. So there are certain articles which are now coming out in the British Journal and other articles. So this was a pilot study. So they concluded that it was objective, a non-contact method, rapid assessment of the vasculature compared to that done by the clinicians on the slit lamp. Yeah. So this was another article in 2022 in which they have done serial photographs, both with fluorescein stain and the angiography. And they have shown that what we see on the slit lamp, the OCTA reveals much more in terms of the limbal vasculature. So now, which seems much severe on day one, you can see that the vessels have started coming back. So most likely it was blanching. And here you can see this is more severe, that is the ischemia. And then even with conservative management, certain cases do heal, but sometimes we tend to overestimate the grade of injury. So the clinical examination alone is insufficient to assess the presence and extent of ischemia. So, and obviously one more study now published this year has shown that it has more impact and more sensitive than just clinical examination alone. So we need more awareness. Prevention is the best cure. So we need more awareness campaigns, that especially the handling of tuna packet by children. So the take clinic message is it's a true ocular emergency, as we all know, and we need a newer classification system which includes the depth of scleral ischemia for better treatment and prognostication. And if you use a OCTA, which is very difficult because the machine is expensive and not available everywhere, still we don't have a standardization and accuracy and whether it is reproducible and reliable in different clinics across the globe. And with this, I would like to invite all of you to next year to Kolkata for AIOC 2024. You can scan the code for payment and get a discount till 14th May.